Welcome to Chapter 5, covering the nervous system. Jumping right in, the nervous system is made up of neurons, which are specialized nerve cells. Motor neurons transmit efferent signals from the brain to the periphery, and sensory neurons transmit afferent signals from the periphery to the brain. Interneurons are the neurons between neurons. Looking back at motor neurons, we have those divided into two groups, and those groups are separated based on where their cell body is located. So upper motor neurons have their cell body in the cerebral cortex, brainstem, or cerebellum. Damage to these neurons results in an increase in motor presentation. So we see hypertonia in the form of spasticity and hyperreflexia. Lower motor neurons have their cell bodies in the anterior horn of the spinal cord, and damage to these neurons results in a decrease in motor presentation. So we see hypotonia in the form of flaccidity and hyporeflexia. I would familiarize yourself with these symptom presentations the way that they're outlined on page 58 in table 5.1. Neurons are made up of different parts. The dendrite is the part of the neuron that receives the impulses to transmit to the cell body. At the cell body, which is the central structure of the cell, the impulse is interpreted and a response is generated. And then that response is then sent out from the cell body via the axon, which conducts impulses away from the cell body to other cells. Here we can see a motor neuron on the left and a sensory neuron on the right. I would familiarize myself with each of these and be able to tell the difference between them. Motor neurons, which are our efferent neurons, transmit information to the central nervous system from the periphery. They have large cell bodies with multi-branched dendrites and long axons that exit the anterior horn of the spinal cord with other axons of the same spinal cord level. Our sensory neurons, on the other hand, are afferent neurons that transmit information from the periphery to the central nervous system. Their cell bodies lie in the posterior root ganglion and are often more centrally located along the neuron. The synapse is the space where communication between neurons occurs. It's a small gap that is a junction between the axon of one neuron and the dendrite of another neuron, or the axon and the terminal location, such as the muscle. Neurons communicate via neurotransmitters, which are chemicals released at the synapse, which either activate or inhibit receptors on the receiving neuron. And so the motor end plate is going to be our terminal location of the muscle. The motor end plate is a point where the nerve enters a muscle, and the neuromuscular junction is the synapse between the axon and the muscle. Within the central nervous system, we have gray matter and white matter. Gray matter is unmyelinated cells and nerve fibers, and white matter is made up of myelinated cell bodies and cell axons and nerve fibers. It's very important to understand that myelin speeds up the rate of impulse conduction within the nervous system so that nerves can transmit signals faster. Use this image as practice to help you understand the structure of the nervous system at the level of the spinal cord, and see if you can identify the afferent neuron, the efferent neuron, and the interneuron. If you have any questions, bring those to class. The nervous system is protected by several layers, the most external of which is bone. So in the head, the skull protects the brain, and in the body, the vertebrae protect the spinal cord. We can see in the last slide how the spinal cord travels through the vertebral foramen of the vertebral column, but the peripheral nerves of the spinal cord need to exit between the vertebral levels. And so we're looking at the spinal nerve roots that exit through the intervertebral foramen, which is formed by the inferior vertebral notch of the superior vertebra and the superior vertebral notch of the inferior vertebra to give you that nice opening. This helps to create a well-encased protection to the spinal cord while allowing for the spinal nerve roots to reach the rest of the body. Underneath the bony protection, we have the layers of the meninges that protect the brain and spinal cord. Most superficial is the dura mater, which is the thick, fibrous outer layer. Under that, we have the arachnoid mater, which is a thin, fragile layer. And then below the arachnoid mater, we have the arachnoid space, which is where cerebrospinal fluid flows. And then the deepest portion of the meninges is the pia mater, which adheres to the surface of the central nervous system and contains blood vessels. The cerebrospinal fluid flowing through the subarachnoid space is another layer of protection because this fluid acts as a shock absorber. The brain is the main portion of the central nervous system that processes information and formulates responses, and the brain is made up of the cerebrum, the brainstem, and the cerebellum. The cerebrum is broken down into hemispheres, and each hemisphere has four lobes. The two hemispheres are connected at the midline via the corpus callosum, and the brain has increased surface area because of the grooves created by the gyri and sulci of the brain, allowing for more cells in a consolidated area. The lobes of the brain include the frontal lobe, which is responsible for movement, expressive speech, and personality. The parietal lobe is responsible for sensory information. The occipital lobe is responsible for vision and the recognition of size, shape, and color. And the temporal lobe is responsible for behavior, hearing, and language reception. Pause to take a minute to think about the functions of each lobe. How would impairment to this lobe of the brain present in a patient in therapy? Bring your responses to class and be prepared to share with the class what those impairments might look like and why the patient might present in that way. Deep structures of the brain that are important for us to know and understand include the thalamus, which is the relay station for sensation. Pain perception also lives in the thalamus, and so without the thalamus, we would not feel pain. The hypothalamus is responsible for hormonal regulation and behavior, and the basal ganglia is responsible for coordination of movement. The basal ganglia is the structure affected in patients with Parkinson's disease, which is why those patients struggle with movement coordination. The brainstem is another deep structure of the brain that has its own components. The brainstem is made up of the midbrain, which is responsible for visual reflexes, the pons, which is a major connection station for fibers to the cerebellum, and the medulla oblongata, which is responsible for regulation of the regulation of respiration, regulation of blood pressure, and heart rate. Damage to the brainstem can be fatal because of how important of a role it plays to regulation of vital functions. This cross section of the brain lets you see these different parts we've talked about. You can see the seahorse in the middle there. You can see the hypothalamus makes up the head of the seahorse, with the thalamus making the eye of the seahorse, and then the brainstem makes up the body of the seahorse, where the pons is the belly and the medulla is the tail. The cerebellum is the mini brain that sits behind the pons and the medulla, and it controls muscle tone, coordination, and posture. The cerebellum should be really closely correlated in your brain with coordination. When you hear the cerebellum's impacted, your thinking coordination is impacted. The spinal cord is the extension of the central nervous system from the brain, extending from the medulla oblongata. It transmits information between the brain and the rest of the body and is located within the vertebral canal or foramen, which is formed by the neural arch and the vertebral bodies of the vertebra. The spinal cord extends down the vertebral column, terminating at L2 into this tapered shape called the conus medullaris. Extending from the conus medullaris is the filum terminale, which is a thread-like filament that attaches to the coccyx to help secure the spinal cord. We also have the spinal nerve roots extending below the conus medullaris, which you can see in this picture look like a horse's tail, which is where it gets the name cauda equina. Arising from the cerebrum and the brainstem are the 12 pairs of cranial nerves. So we have the mnemonic, on old Olympus towering tops, a Finn and German viewed some hops, to help remember the 12 cranial nerves. And then we have, some say marry money, but my brother says big brains matter most, to remember the type of information that each cranial nerve transmits. So starting at the top here, we have cranial nerve 1, the olfactory nerve, which is a sensory nerve for smell. Cranial nerve 2 is the optic nerve, which is a sensory nerve for vision. Cranial nerve 3 is the oculomotor nerve, which is a motor nerve for movement of the eye. Cranial nerve 4 is the trochlear nerve, which is also a motor nerve for muscles of the eye. Cranial nerve 5 is the trigeminal nerve, which has both sensory and motor function for sensation of the face and muscles of mastication. Cranial nerve 6 is the abducens nerve, which is another motor nerve that controls muscles of the eye. Cranial nerve 7 is a facial nerve, which has both sensory and motor function, providing sensation to the tongue and motor control of our facial muscles. Cranial nerve 8 is the vestibulocochlear nerve, which provides sensory information about hearing and equilibrium. Cranial nerve 9 is the glossopharyngeal nerve, which is both sensory and motor, providing sensory input for taste and to the pharynx and middle ear, and then motor control for muscles of the pharynx. Cranial nerve 10 is the vagus nerve with both motor and sensory input to the heart, lungs, and gastrointestinal tract. Cranial nerve 11 is the spinal accessory nerve, which is a motor nerve providing innervation to the sternocleidomastoid and the upper trap. And last but not least is cranial nerve 12, which is the hypoglossal nerve, a motor nerve for muscles of the tongue. We will be doing cranial nerve testing in class as a part of lab, and so being able to understand what you are assessing with each one of these nerves will make performing the test easier. At the bottom here, you can see the cranial nerve face that is drawn to help you remember the function of each cranial nerve. If you don't understand this face, please remind me to draw it for you in class as part of your questions when you come to class. After cranial nerves, we have our spinal nerves, and so these are arising from the spinal cord. We have 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Since there are more cervical spinal nerves than there are cervical vertebra, there is a change in how the spinal nerves emerge from the vertebral column at the transition to the thoracic spine. So the first 7 cervical spinal nerves exit the vertebral column above the corresponding vertebra. Then the 8th cervical spinal nerve exits below the last cervical vertebra, C7, causing a shift where all of the remaining spinal nerves exit below their corresponding vertebral level. Each spinal nerve carries both sensory and motor information. The sensory information carried by the spinal nerve corresponds to a specific dermatome, which are areas of skin that are supplied with sensory fibers of the specific spinal cord level. So there's a section of skin where the sensation all corresponds to one spinal nerve root level. We will take a look at a picture of that in a couple of slides here. The motor information in a spinal nerve supplies that level's myotome. Myotomes are all of the muscles innervated from a specific spinal cord level, and so we have specific motions or movements that are correlated with specific spinal nerve levels. There's a summary of those at the end of this PowerPoint, so we'll go over those then. Because the body is well designed with fail-safes in place, we also have these plexuses that form from the spinal nerves where the nerve roots mix and redistribute. Because of this mixture, injury to a single nerve root level without injury above or below will typically present with diminished sensation or motor function for the dermatome and myotome and not a completely absent sensory or motor function. Here is an image to show the skin areas innervated by the spinal nerve root levels. There's a rough correlation to motor function with this as well, but again, we will talk about those specific points and motions at the end of this, and you will practice testing dermatomes and myotomes in class. A plexus is a network of nerves that branch and combine to form peripheral nerves. So the spinal nerve roots branch out from the spinal cord, come back together to mix up with each other, and then branch off into the peripheral nerves so that ultimately our peripheral nerves have origins from more than one spinal cord level. There are 3 major plexuses of the body, the cervical plexus coming from spinal cord levels C1, C4, and we're not going to touch on that one as much today. But then we also have the brachial plexus from levels C5 to T1 to supply the upper extremity, and then the lumbosacral plexus from L1 to S3 for the lower extremity. For the upper extremity, we look at the brachial plexus, which again originates from spinal nerve roots C5 to T1 and forms several peripheral nerves, but the 5 major ones are the musculocutaneous, axillary, radial, median, and ulnar nerves. The musculocutaneous nerve should be associated with the biceps brachialis and coracobrachialis, so we'll think elbow flexion there. The axillary nerve innervates the delt, so we'll think of shoulder abduction. The radial nerve innervates the extensors of the upper extremity, like the triceps and the wrist and finger extensors. The median nerve innervates the pronators and then the thenar eminence, and then the radial wrist flexors. So on the radial side of the wrist, the median nerve is responsible for the wrist flexors there. And then the ulnar nerve innervates the hypothenar eminence and the ulnar wrist flexors. Understanding the areas and the muscles of innervations for these major peripheral nerves is important. And so whether you need more visual or verbal information to understand that, I would reference figures 521 and table 5.4. The lower extremity is going to be innervated by the lumbosacral plexus, with our major branches being discussed here. So we'll talk about the femoral nerve first, which innervates the hip flexors and knee extensors. Our obturator nerve, which is going to innervate our hip adductors. The superior gluteal nerve for hip abduction, going to glute med and TFL. The inferior gluteal nerve for hip extension, that's going to innervate our glute max. Then we have the sciatic nerve that leaves the plexus to innervate hip extensors and knee flexors of the hamstrings, but then the sciatic nerve actually splits at the knee to form the tibial nerve, which innervates the plantar flexors, and the common fibular nerve, which wraps around the fibula to the anterior of the leg to innervate the dorsiflexors. Again, I would familiarize yourself with figure 527 and table 5.6 for this information. Stretch reflexes are reflex arcs that take in sensory information to quickly generate a motor output. The sensory receptors at play here are the muscle spindles, which activate neurons in the anterior horn of the spinal cord, where our lower motor neuron cell bodies live, to produce a brief muscle contraction. Muscle spindles are going to respond to tension, or both of these are, but here we'll talk about the muscle spindles responding to tension so that a quick stretch is placed on the tendon. It generates a quick muscle contraction that we're familiar with when we think of checking reflexes. The Golgi tendon organs act to inhibit that lower motor neuron that was activated by the muscle spindle. So signals from the GTOs travel a little bit slower, and the activation from the muscle spindles happens faster. But the signal from the GTOs gets there after the signal from the muscle spindle to make sure that the signal stops and that the muscle contraction is brief. We use stretch reflexes to assess nervous system function, and to do that clinically, we assess deep tendon reflexes, where a quick stretch is provided to the tendon using a reflex hammer and just hitting on the tendon. We'll look at the nerve roots being assessed by the different reflexes you'll check in class on the next slide, but we also want to know how we document when we test reflexes. And so we use a scale that goes from 0 to 4+, starting in the middle because I think that makes the most sense. A normal reflex response is a 2+. So most people are going to be a 2+ on their reflexes. If there's an increased response, you would score the patient a 3+. And if there is repetitive contracting, we call that clonus and score it a 4+. Patients with upper motor neuron dysfunction are going to be more likely to score a 3+ or a 4+ with reflex testing. Moving down from a normal response, if we see a decreased response, we would score a 1+, and if there is no reflex present at all, the patient would be scored a 0. Patients with damage to a lower motor neuron are going to be more likely to present with a 1+ or a 0 in reflex testing. In class, we will assess reflexes on each other. We look at the biceps reflex to assess the integrity of spinal nerve roots C5, C6. Triceps is checked to assess C6, C7. We will assess brachioradialis for C5, C6 integrity as well. And then for the lower extremity, we have the patellar reflex for L3, L4, and the Achilles reflex for assessing S1, S2. I will demonstrate how we're going to assess these reflexes in class, and then you guys are going to check them on each other during lab. Our autonomic nervous system regulates visceral structures, so it controls digestion, reproduction, and cardiopulmonary organs. Our autonomic nervous system operates outside of our conscious control, and it breaks down into two parts: our sympathetic nervous system, which is responsible for our fight or flight response, and our parasympathetic nervous system, which is responsible for our rest and digest response. We're going to touch on just a few of the pathologies of the nervous system here, but we will dive deeper into a lot of these during neurology. Our congenital defects of the nervous system include pathologies such as spina bifida, hydrocephalus, and cerebral palsy. Congenital defects, remember, are ones that patients are born with, and again, we will elaborate on those when we get into neuro. Spinal cord injury is an acquired injury that can cause different presentations, such as paraplegia, which involves the trunk and legs, and tetraplegia, which involves the trunk, legs, and arms. Presentations are going to vary depending on the location of the injury and whether it was complete or incomplete. And spinal cord injuries are most often caused by trauma, but they can also be a result of tumor or blood clots. This picture helps to show some of the different presentations of spinal cord injuries. We will dive deeper into this when we get into neuro, and it'll be important for you to understand the presentation for each type of injury then. But use this visual now just to give yourself an idea of the different presentations and to create a foundation for yourself. Other pathologies of the nervous system include muscular dystrophy, which has several types, but Duchenne's is going to be the most common. And muscular dystrophies are disorders between the muscle and the neuromuscular junction, so where the nerve meets the muscle. Degenerative diseases include ALS and Alzheimer's, where there is degradation of the nerve cells. Comparing that with demyelinating diseases, where the nerve cell remains intact but the myelin degrades, and that's going to include things like MS, where we see demyelination of the axons of the neurons, so transmission speed is reduced. And lastly, on the pathologies, these are the pathologies to the peripheral nervous system, with the most common being a neuropathy, which is a loss of nerve function, be that sensory or motor, distal to the site of injury. Neuropathies typically happen as a result of trauma, circulation issues, or secondary to other pathologies like diabetes. Bell's palsy is a neuropathy that affects the facial nerve. Scapular winging results with damage to the long thoracic nerve, which innervates serratus anterior. Thoracic outlet syndrome is where the brachial plexus is impacted between the clavicle, first rib, and scalenes. And then foot drop occurs with damage to the common fibular nerve. And then a neuroma is a bundle of neurovascular tissue that can create a painful mass. We are going to wrap up here by circling back to dermatomes and myotomes to prepare you for class. The places listed here are specific testing sites for our dermatomes. You will see these noted visually in your lab handout, but in case there's any confusion of the visual images, this gives a specific location for you. So C3 is assessed at the supraclavicular fossa, C4 at the top of the AC joint, C5 at the lateral antecubital fossa, remember that's the front part of the elbow, C6 at the thumb, C7 at the tip of the middle finger, C8 at the tip of the pinky. T1 is assessed at the medial antecubital fossa, and then T2 at the apex of the axilla. Then we can assess lower extremity integrity with L1 checking at the anterior groin, L2 at the middle anterior thigh, L3 is assessed at the medial femoral condyle, L4 is assessed at the medial malleolus, L5 is assessed on top of the foot or the dorsum of the foot, S1 is on the lateral heel, and S2 is the popliteal fossa or the back of the knee. And for our myotomes, we assess C1, C2 by looking at cervical flexion, C3 is lateral cervical flexion, C4 with scapular elevation, C5 with shoulder abduction, C6 with wrist extension, C7 with elbow extension, C8 with finger flexion, and T1 with finger abduction. To assess myotomes of the lower extremity, we assess L2 with hip flexion, L3 with knee extension, L4 with dorsiflexion, L5 with great toe extension, S1 with plantar flexion, and S2 with knee flexion. We will practice assessing all of these, all of the dermatomes, all of the reflexes, all of the myotomes, have you guys draw on each other in lab for where the nerve patterns go so that you can better familiarize yourself with that. And so we'll do a lot of things in lab to make these things make sense. Until then, make sure that you write down any questions that you have over this lecture. You bring your responses to the impairments from the lobes of the brain to class to discuss, and you come to class prepared to complete all of these lab activities.